Thank you, Rishi. The topic given is endothelial keratoplasty in congenital hereditary endothelial dystrophy and posterior polymorphous dystrophy. I think you've done something to the aspect ratio. You've changed the aspect ratio, it's coming slightly compressed. That's okay. Congenital hereditary endothelial dystrophy, it's a rare corneal dystrophy. However, if there is consanguinity in the family, then there is an increased incidence, so maybe slightly much more in the Middle East and Southern India. Presence as diffuse clouding of the cornea. It can two types. It can present right from birth when it is supposed to be CHED type 2, which is autosomal recessive, or it can present gradually by 1 year of age when it is termed as CHED type 1, and it's autosomal dominant. And in recent times, they are considering clubbing this with posterior polymorphous dystrophy. There is thickened cornea and the thickened decimus membrane as well, and paucity of endothelial cells as seen on confocal microscopy. There is a diffuse limbus to limbus diffuse edema, and it can often be confused with congenital glaucoma because the cornea is quite thickened. The measurement of the IOP can be higher, and a lot of times we see these patients where trabeculectomy has already been done. Let's just show you two clinical cases where you can see there is diffuse corneal edema, then there is increased thickening of the cornea. And the other one, that's another of my cases where there is band-shaped keratopathy in addition to the chronic edema. In contrast, posterior polymorphous dystrophy is also a rare corneal dystrophy with autosomal dominant inheritance. It's usually asymptomatic, and corneal edema need not be present in all cases. Patients can also present with peripheral anterior iris abnormalities, correctopia, elevated intraocular pressure, and often can be confused with eye syndrome. The three possible patterns of presentations: you can have vesicle-like lesions, band lesions, and diffuse opacities. You see polymecathism and pleomorphism of the endothelial cells, especially lining the band. And confocal microscopy can be useful to differentiate between posterior polymorphous dystrophy and eye syndrome. And if there is presence of corneal edema, then corneal transplantation can be performed. Just to show you one of the cases where you can see this snail track of the band kind of appearance, and there is sometimes duplication of the decimus membrane with multi-layered endothelium. Now, in both these conditions, when you look at pediatric penetrating keratoplasty, it can be challenging. It's quite different from doing an adult penetrating keratoplasty. Number one, children have a higher rate of graft rejection than adults, and because of the lower scleral rigidity, increased fibrin reaction, and positive vitreous pressure, performing surgery is always a challenge, and often, if you're not used to it, you may end up having a spontaneous expulsion of the crystalline lens. These patients are difficult to examine in the outpatient department and often require frequent examination under anesthesia, and if you place sutures, then sutures need to be managed appropriately, and if you don't manage the sutures, you can often result in suture-related complications, and because of the sutures, you also have to tackle the changing refractions with the suture removals, and that again plays a very important role when you are managing amblyopia. In contrast, endothelial keratoplasty has several advantages. The surgery is more controlled due to a closed anterior chamber. The absence of sutures result in a faster visual recovery and eliminates the need for suture management. And recent studies have shown that endothelial keratoplasty definitely has a lower risk of rejection compared to penetrating keratoplasty. And because of lesser induced astigmatism, maybe the management of amblyopia could be better. There are several studies that have shown that you can perform both dissect and dissect successfully in CHED and with good outcomes. And some of the studies have come out of L.V. Prasad Eye Institute, and this one study by Dr. Ramappa and Jatin Asher, where they have compared one eye PK and the other eye dissect, and they have found that at 1 year all the grafts were clear. In the dissect group, the astigmatism was lower as expected and had faster stabilization of refraction. However, the advantage the PK group had was that the grafts appeared much more clearer than the dissect graft because the cloudy cornea the edema did settle down, but a slight haze was still present. Now, in terms of, we know that when you do dissect in these eyes, stripping of the decimus can be a major issue, especially if you're doing it in very young children below the age of 1 year. So Busin and colleagues did publish a paper where they did not strip the decimus in less than 1 year of age, and they found that the dissect donor attached, although in 4 out of the 6 eyes, rebubbling was necessary. And so this is again something that can be considered, that if you're doing a procedure, there was another paper from L.V. Prasad Eye Institute where they looked at NDSEG, and they found that which was quite favorable for management of CHED. Looking at another nice paper from same from Dr. Ramappa and their group, is that they looked at a retrospective study looking at all the posterior polymorphous dystrophy. Usually the mean age at presentation is much higher, it's about 32.5 years, and with a slight male preponderance, and mostly they have a bilateral involvement. You can have, again, in terms of the presentation, most common are the vesicles in the band. Edema is only about about a smaller percentage, about 20% you can say, and with anterior segment changes again in one eye. And out of the 16 eyes, they had done penetrating keratoplasty and decimal stripping endothelial keratoplasty in equal numbers, and they found that all the graphs remain clear till last follow-up. So patients who have visually significant corneal edema may require keratoplasty, and DISEC seems to be a good option for such cases. This is a recent paper published last year where Dr. Rootman's group, they tried performing a DMEC in a patient with posterior polymorphous dystrophy, and they were not successful. And this patient, despite rebubbling, it did not stick, so they had to go back and do a DISEC. And after doing the DISEC, the visual acuity improved to 20/70 and 20/60 with good endothelial cell count. Now, let me share two of my recent cases that I did. These were brothers and sisters. This is the brother's eye, where you can see there is a diffuse bilateral corneal edema. And so let me just go to his next slide. Yeah, so his clinical data is that his pre-op uncorrected vision was 3/60, and with best spectacle corrected -4 with -3, the vision improved to 624. He had normal intraocular pressure, so we decided to go ahead and do a DMEC in this case. So you can see that that's the eye. That's an 8 millimeter mark I'm making. So the corneal diameter is slightly reduced. The 8 millimeter mark is almost going up to the limbus. Removal of the epithelium, the edematous epithelium, did improve the visualization. We did an inferior vertical paracentesis and pulled out the iris and did a generous inferior PI. And then we made 2 paracentesis at about 7 o'clock and 12 o'clock position. And then we went ahead with a temporal clear corneal incision, about 3 millimeter. That's a 2.8 keratome, and we just enlarged the size a little bit. We did not attempt to remove the decimets, and since we had instilled some cohesive viscoelastic into the eye and pilocarpine, we did remove that. That's the donor tissue, the DMEC donor that's prepared and marked. It's loaded onto the glass injector. We did use an AC maintainer to keep the chamber formed, and we went ahead with the glass injector, the tip crossing the pupil, so we didn't want the decimal scroll to go try and make its way behind the pupil. And that's the insertion of the donor. We removed the AC maintainer after that, and then we closed the wound. And when we were inserting, we tried to insert in an orientation that the opener on the scroll is facing upwards. So now you can see that we did get our scroll in the right orientation, so we didn't have to, manipulate it too much to try and, flip it over or something like that. And by gentle tapping of the surface, using 2 cannulas, we were able to open the graft. And at the end of it, we placed 20% SF6 into the eye. That's the mark that we had made, the F stamp that we had created. So instead of using air, knowing that in these eyes, the tamponade may be required for a longer period of time, and since we have not stripped the decimers, we know that a donor DM sticks better to the Bayer stroma than to the host decimus membrane. We place SF6 complete fill, and then we put a bandage contact lens on the eye. That's how the patient looked at 1 month post-op, and you can see that the cornea looks much clearer than what it looked pre-operatively, and his visual acuity in the post-op with best spectacle corrected of -4 with -5 cylinder, possibly because of the suture that we placed temporarily, his visual acuity improved to 612. His specular count was 2,247 cells per millimeter square, and the pachymetry, if you see pre-operatively, was 864 microns, and post-operatively that had reduced to 539 microns. So there was a good resolution of the corneal edema. That's his sister, who was 6 years old, And she had, in addition to the corneal edema, she had bilateral band-shaped keratopathy, possibly because of the chronic edema that she had. That's her. Similar surgery was performed. That's her post-op appearance. She was a little less cooperative for taking photographs, and she did have a little bit of nystagmus, possibly because of the band-shaped keratopathy and the much reduced visual acuity that she had. So her visual acuity from pre-op of 3 by 60, the best spectacle corrected visual acuity did improve to 624, a specular count of 1876, and even in her case, her pachymetry from 872 improved to 553, so there was good resolution of corneal edema. So endothelial keratoplasty seems to have several advantages compared to penetrating keratoplasty in managing pediatric corneal edema. Dissect or dissect can be performed successfully. Removal of host TM may not be necessary in these eyes, and attempt to try and remove the host TM can sometimes make your inner surface very irregular. DMEC using gas tamponade with either SF6 or C3F8 non-expansile mixture can be attempted, although surgically challenging when compared to dissect. Thank you for your patient hearing.